Welcome to Key Insights from Lymphoma Myeloma 2017, an international congress on hematologic malignancies being held here in New York City. Today is day one of the conference, and we are very pleased to have Dr. Ruben Levitsky with us, who is the chair of the myeloma section. Dr. Levitsky, welcome.
Hello.
We heard some exciting papers here today, and would you kindly reflect to us what is the key idea in terms of treatment for the untreated myeloma patient who's otherwise fit? How would you approach him? How would you approach him? What do you think is the, quotes, gold standard, if there is a gold standard, for the treatment of previously untreated or treatment-naive patients with multiple myeloma?
So we have the privilege of having 4 key opinion leaders discussing various topics in the initial therapy for multiple myeloma. And it was a clear understanding that one of the most important goals is to achieve the maximum deepest form of cytoreduction to the point of minimal residual disease negative state. There was a lot of controversy as how do we define minimal residual disease and what's the future, talking a little bit about different techniques on flow cytometry and on next generation sequencing as the best standards moving to the future. It is not clear, however, what's the path to reach that minimal residual disease negative state. Other authors also describe that the same approach could be for the unfit patients and even for the frail. But by starting with the fit patients, as per your question, it was clear that the combination of proteasome inhibitors, immunomodulators, and corticosteroids, followed by a consolidation form, would be the standard path. The consolidation is now considered stem cell transplant and still one of the most cost-effective forms to reach to that point. With the advent of monoclonal antibodies, in particular daratumumab, there is multiple clinical trials looking to incorporate daratumumab to the induction regimen, such as bortezomib-len-dex or carfilzomib-len-dex. It is unclear whether giving it together or giving it in sequence is the best way moving forward, but everybody agrees that the clinical trials should explore that. Moving also forward, it is necessary to evaluate minimal residual disease at different stages, during induction, during consolidation, and in maintenance, and for how long maintenance would go. Maintenance can be abbreviated at 2 years if MRD remains negative, and that's one of the questions of the clinical trials moving forward. In the unfit patients and in the frail patients, the incorporation of monoclonal antibodies, albeit in an intravenous form or in a subcutaneous form, can also lead to MRD negative state. So there are open clinical trials here in Europe that are looking at that question.
So I guess I can conclude that VRD is kind of a gold standard for right now as initial induction therapy, and that we are now looking to see if we can replace the V with carfilzomib. And there's also the question of whether we could maybe even possibly add an antibody to this 3-drug combination. Hopefully it won't have us encounter more adverse events as a result. Now, one of the questions that always seems to need to be answered is, my understanding is that the auto transplant is an excellent means for consolidating and getting us to MRD. But suppose your combination treatment can obtain the same MRD. Do you think there's still a need for transplantation?
Well, the Dana-Farber Institute and IFM combined trial recently published in the New England Journal of Medicine show that achieving an MRD with either path will lead to similar results and excellent results. So it's not the procedure in which leads the best results, but rather the biomarker and the tumor debulking. So at this point, we are not clear whether it's the best path, but certainly the current standard adds a stem cell transplant.
So minimal residual disease, however you want to define that, is really the goal for doctors out there treating their patient.
That, and of course reversing the comorbidities associated with the disease, allow for stem cell mobilization that, even though might not be used frontline, will be of high value as a rescue.
Oh, good. So now tell me, how would you approach a patient who has resistant or refractory disease, patient who has come out of a good remission and now is seeming to progress? How would you approach this patient who gets started, let's say, for instance, with VRD, may have had a transplant or may not have had a transplant, and may then be on maintenance? How would you approach this patient?
There are many factors that need to be taken in account when somebody is in front of a patient in relapse. A minority of patients will have a biochemical relapse without any clinical effect in any evidence of tissue damage. Some of the authors that presented in the debate in our conference suggested that small modifications, such as increasing the dose of lenalidomide in patients who are receiving lenalidomide maintenance, would be a good approach, or increasing the steroids, or adding clarithromycin, adding a second agent at that point, perhaps an oral proteasome inhibitor. What is not clear at that point is just adding to already a resistant drug will add much time in that sense. So if the patient has a biochemical relapse, but the initial presentation of the patient was a stormy presentation with hypercalcemia, bone disease, renal failure, I would not recommend to wait. I would recommend to change class to a non-resistant, possibly a combination without combined toxicity, and change even a type of drug. So for instance, now we have approved of daratumumab in the second line, and therefore it could be used in combination with bortezomib, with lenalidomide, and even with pomalidomide. One of the best combinations that are there evaluated in phase 2 is the carfilzomib, lenalidomide, and dexamethasone, which also would be a great option.
Would you add daratumumab at this point as well?
Yeah, so daratumumab, it's part of the daratumumab bortezomib regimen, or daratumumab lenalidomide regimen, or the pomalidomide. But we need trials to compare KRD versus dara-pom, or KPD versus dara-pom. That will lead to best regimen in terms of toxicity and efficacy.
Well, it seems like monoclonal antibodies have certainly taken hold in the myeloma therapeutic arsenal. Are there any problems with giving monoclonal antibodies? What are the toxicities for those at home?
Well, the immediate reaction of infusion is very well described as its prophylaxis and process to give. It's a slow infusion, and that adds some nuances in the administration of the drug, but most of the patients, even the elderly, tolerate it very well. So once has passed the first infusion, in general, they're very well tolerated. Neutropenia, infections can occur, and someone had to be vigilant of these type of infections, and using prophylaxis in right sequence would be also important, such as zoster prophylaxis and perhaps antimicrobials. Long term, we don't have much data, but it appears that the signal of secondary neoplasms are not seen with the monoclonal antibodies, but it's still early to know.
It seems now there was some controversy over whether one should be maintained or not maintained, regardless of whether you had a transplant or not. I'd like your opinion on whether we should maintain, even in a patient who may have MRD, and also if you want to maintain the patient, what would be your choice for maintenance? Would it be an IMiD? Would it be a proteasome inhibitor, maybe an oral proteasome inhibitor? Would you use it with steroids, without steroids? How do you go about maintaining your patient?
I think the data now clearly identifies an advantage for progression-free survival for those patients receiving maintenance. The question of limited maintenance versus maintenance till progression or toxicity has been resolved probably in a meta-analysis in which shows that continuous maintenance by lenalidomide does provide advantage. And it appears to be that the clonal selection that occurs under the pressure of lenalidomide is less and is reduced as you will compare it with a non-maintenance state in which you let free all potential clones to relapse faster. The overall survival signal has been confirmed in 2 large randomized trials, and therefore our recommendation, at least here in Cornell, is lenalidomide maintenance until progression or toxicity. The risk of secondary malignancies is there, particularly in those patients who have received alkylating agents at high doses. We don't see it in patients who have only received immunomodulators with proteasome inhibitors, at least not higher than the expected incidence of secondary neoplasms. But that's a factor that needs to be considered. Certainly the risk of progression and death by myeloma is way higher than the use of immunomodulator maintenance and the risk for secondary malignancies, hematological malignancies there. Lenalidomide is by far the longest and better scrutinized maintenance regimen. However, there is data for bortezomib as a maintenance regimen in a limited fashion or in a continuous and in 3 different schedules, either weekly 4 out of 6 schedule or every other week schedule of subcutaneous bortezomib, or a full intense cycles of bi-weekly for 2 weeks every 2 or 3 months. None of those schedules have been randomly investigated against lenalidomide or against each other, so right now we cannot ascertain which one is the best maintenance regimen. Now, with the advent of oral proteasome inhibitors, which are highly convenient and highly efficacy, like once a week ixazomib, it opens the opportunity to either use it as a single agent, as a maintenance in that sense, or even in combination with lenalidomide, particularly in patients with high-risk myeloma.
So tell me, what sort of response rates are we getting in a treatment-naive patient who gets, bortezomib, lenalidomide, and dexamethasone? What can we anticipate in the average patient in terms of overall response and complete response, or MRD? What can we anticipate of the average person out there being treated?
But that depends on what study you look at. But the overall response with any triplet reaches 90%. similar to what we saw when we combined clarithromycin, lenalidomide, and dexamethasone. So I don't think the overall response is a reliable marker anymore. Now, complete response, as originally reported by the Boston group, may reach at 4 cycles about 30% only, whereas our BIRD, clarithromycin, lenalidomide, and dexamethasone reached 40% of complete remission. However, similar results can be obtained with CyBORD-D. Now, with the advent of carfilzomib in the induction regimen, those numbers can increase to 50% or higher. Being modest, can also give MRD negative by highly sensitive techniques up to 40 to 50%. So we expect as the induction regimens improve, that can also increase and probably get better when we add the monoclonal antibodies.
Do you see ultimately a role for daratumumab early on in terms of inducing even a more profound MRD in patients, using it up front, although it's not indicated at this time?
Absolutely. We have discussed today, and we have already seen many clinical trials in which they are incorporating daratumumab in the VRD regimen, in the KRD regimen. They are using it in the elderly, either intravenously or subcutaneously. So it is indeed a good addition for the future.
Yes. Now, we'd also like your opinion on transplantation. What would you recommend in terms of drugs to be used in autotransplantation? In particular, the concern about combining an alkylator with Revlimid maintenance. Do you think that it makes any difference what conditioning regimen we use, or do you think they're all pretty much the same? I guess the most common regimen would be Alkeran or phenylalanine mustard. Are there any other combinations that you think that might be of use as well?
Well, there is not enough research in the consolidation aspect of the transplant. Certainly there is drugs such as bendamustine that are being looked at in combination in our group with melphalan. BCNU has been looked at as an additional alkylator, and busulfan by the Spanish group. None of them have appeared to really significantly increase the efficacy of the transplant per se, but certainly more research is required in that arena.
And lastly, we are hearing some exciting data about BCMA, B-cell maturation antigen, as a target for CAR T. Would you care to reflect on where do you see CAR T emerging as a possible therapeutic option in myeloma?
Well, it is very important to mention that BCMA can also serve as a biomarker, and there might be research that will help us determine tumor burden just by measuring BCMA. Additionally, it is a great target, and many approaches to try to use it as a vehicle for immunotherapies are on their way. CAR T being one of them. Excellent results of several groups have showed. It is still to be determined to what is the level of expression that each patient must have to be efficacious. I don't know if that's known yet. It is also important to know what's the kinetics of expression of BCMA through manipulation of immune therapies. It is also interesting that other therapeutics are being explored through that antigen, such as the BiTEs and other immunoconjugates. So excellent target, Much research is required, but it's a very exciting area of development.
Well, thank you very much, Dr. Nowitzki, for your observations on day one at Lymphoma Myeloma 2017, an International Congress on Hematologic Malignancy. I wish you good day from New York.